This program is brought to you by Emory University.
Good morning, everyone. Welcome to Friday Morning Fellows Conference. As you can see, our speaker this morning is Dr. Saba Islam, one of our fourth-year fellows in the clinical investigator track. She originally from Nevada, did her undergraduate studies at the University of Pennsylvania, then medical school and internal medicine residency at Boston University, and then joined our clinical research track, working with Dr. Kayumi, and is on track to graduate next June, where she's looking to become a heart failure specialist next year. And she's going to talk to us today about fulminant myocarditis. So without any further ado, Dr. Islam.
Thank you, Dr. Williams, for the introduction. All right. Hi, everyone. So today we will be talking about a few cases on fulminant myocarditis. So three learning objectives are recognizing the four common presentations of fulminant myocarditis. We'll focus mainly on lymphocytic and giant cell and touch briefly on necrotizing eosinophilic and immune checkpoint inhibitor related myocarditis. We'll talk about the diagnostics, in particular when to get an endomyocardial biopsy, and also talk a little bit about how cardiac MRI can be useful in the diagnosis. Just briefly touch base on the different treatment strategies of the different forms of fulminant myocarditis. So let's start out with our case. So I met this patient when I was on EUHCCU in August. So she's a 22-year-old lady. She has a past medical history of seasonal allergies. And she came into urgent care because she was having a 1-week history of shortness of breath and nasal congestion. But at the urgent care center, she was found to be tachycardic and hypoxic. So they referred her to go to the emergency room, and she presented at Emory St. Joe's. These were her vitals on presentation. As you can see, her blood pressure isn't too bad, 110/83. She was tachycardic, her heart rate was 124, and she was satting 96% on high flow nasal cannula. She was also tachypnic, her respiratory rates were 34. On exam, she had a JVP, she had bibasilar crackles, and she was tachycardic with a holosystolic apical murmur. She had warm extremities and some trace edema. Her labs were significant for a hemoglobin of 8.6. Her platelets were very low, 20. Her K was up 5.5, and her creatinine was up at 1.18. As you can see here, was elevated at 4,500. She was very severely acidotic. Her pH was 6.86, bicarb 7, and 15. So she was sick. So this was her EKG, and as you can see over here, it's sinus tachycardia, rates around in the 120s, overall voltage. And this was her X-ray on admission. So as you can see here, her silhouette is enlarged, and they got a CTP, of course, because she's tachycardic. So no pulmonary embolism was found. However, they did notice these kind of non-specific findings, and we'll come back to this a bit later because this did impact our management a bit. And they recommended getting an echo CTP protocol. So we will look at that as well. Given her hemodynamics, her labs, she was admitted to the ICU. She was started on a bicarb drip and also started on CRRT. The initial concern was for an infection. So initially, I believe she was even given some fluids. So she was started on broad spectrum antibiotics. Infection workup was started. And as the CT ended, we got go. I'll play these images over here. Let's try it. There we go. This is for you. All right. 1 second. I'm sorry about that. Just froze up. I'm sorry. Here. All right. So this is apical view. And then as you can see, her LVEF is 15%. Oh, LV is moderately dilated. The dimensions were calculated to be 6.1 centimeters, and she had severe MR. The other findings were she also had some moderate TR, her RVSP was elevated, and her RV systolic function was moderately reduced. So she continued to decompensate. As you remember, she was having some breathing difficulties when she came in. She was tachypnic. So she ended up getting intubated for hypoxic respiratory failure. She was started on norepi and vasopressin for shock. And at this time, they transferred her to EUH for further management. And given this sort of, viral prodrome that she had and this new heart failure presentation, the suspicion early on was pretty high for fulminant myocarditis. And the thought was it was most likely viral etiology. So we'll go ahead and define what is fulminant myocarditis. So fulminant, the word means coming on suddenly and with great severity. And per the AHA-ACC guidelines, they define it as a sudden and severe inflammation of the myocardium, resulting in myocyte necrosis, edema, and cardiogenic shock. And the long-term outcomes, so this is a more contemporary study. So the long-term outcomes of fulminant myocarditis are not that great. So as you can see here, the 60-day cardiac death or heart transplant rates are approach 28% for a fulminant presentation compared to a non-fulminant presentation. And the 7-year rates are 47.7% in to 10.4% for your normal, general myocarditis. There are many inflammatory cardiomyopathies, and you can put them into 3 different buckets. So infectious is the most common that we see, especially viral infections here. So for example, Coxsackie B, parvovirus, influenza, COVID. You can also have parasites that causes bacterial infections, fungal, protozoal, so such as Chagas. You can also have toxic etiologies. So cancer therapies are definitely part of them. So we'll briefly touch base on immune checkpoint inhibitor myocarditis. And then you have your autoimmune bucket. So you can have cardiac manifestation of a systemic disease. So, your rheumatoid arthritis, scleroderma, etc. Then, we have GCMs, giant cell myocarditis, which is, we should not miss it. And we'll talk about a lot more about it later on in the presentation. And then you have your eosinophilic bucket. So it can be, oftentimes it's usually like a drug reaction, but it can also go along with other hyper eosinophilic syndromes, Church-Strauss or GPA, also with some forms of cancer, you can see it. So the pathogenesis of myocarditis can be broken down into 3 simple steps. And this data comes from animal models. So first, you have your cardiac injury. So the virus comes in, injures your heart. You have exposure of your intracellular antigens, and your innate immune system is activated. And over the next weeks, you have inflammation. And this is against not only the pathogens, but also the heart epitopes, so some level of molecular mimicry. So, and then in the third step, 2 things happen. So for most cases, the pathogen is cleared and the immune system is downregulated and the patient does okay. But in other cases, you continue to have an immune response, and that leads to worsening heart failure. So we'll go back to our case. These are her right heart cath numbers. So as you can see here, RA pressure was 8. So this is on dobutamine 2.5. Her wedge was 18. Her PA-SAT was 62%. Her calculated index wasn't too bad. It was 3.6. So they thought maybe, we could try to wean her. So they tried, but it didn't quite work that well. A repeat echo showed an improvement in the cardiac function. The patient was extubated, so her respiratory status improved. And given this persistent tachycardia, she was started on milrinone instead. She continued to have sort of infectious symptoms. She was having occasional fevers. So she continued to be on vancomycin in the interim. And also we ended up, doing a broad infection workup. And as you can see over here, her infection workup was completely negative, except for this Coxsackie B titers. And her autoimmune workup was also negative. So there are multiple viruses, that are associated with myocarditis. This has been, people started recognizing this starting in the 1950s. So you have your enteroviruses such as adenovirus, influenza viruses as well, and coming back into the contemporary era in 2020, COVID-19, question mark anymore, but COVID-19 caused myocarditis as well. And you can put the that cause myocarditis into a few different buckets. So you have your primary cardiotropic viruses. So these include things like adenovirus, and they can be our Coxsackie virus. And these can be clear from the heart. Then you have your vasculotropic viruses, which likely have lifelong persistence. Include things like parvovirus. You have your lymphocytic viruses, which include things like cytomegalovirus. You have your cardiotoxic viruses, and these work by activating your immune system, and your immune system attacks your heart. And then you also have viruses that work on the ACE2 receptors, and these things include things like COVID. So of course, ID colleagues weigh in, and I will go ahead and read what the ID attending said. This is very difficult to interpret. It could mean a infection with durable antibodies, and therefore has nothing to do with what is happening right now. Or it could be a more recent infection, in which case it may be causally related to the myocarditis. Either way, there's therapy and little clinical data to support immunosuppressive immunomodulatory therapy, even if we were to prove that she has viral myocarditis. So essentially, we don't really know if this Coxsackie is causing her fulminant myocarditis picture. However, we kind of went along with it. We worked, we like to have a diagnosis, so we kind of went along with it. So now I'll talk about, kind of how we diagnose the different types of fulminant myocarditis. So back in the day, it used to be mostly histology based. So this is Dallas criteria. It's not really used anymore. They came out with this in 1986. So what it is the diagnosis of myocarditis can only be made if there's an inflammatory cellular infiltrate with or without associated myocyte necrosis on stained heart tissue sections. And as you can, and there were a lot of limitations to having this diagnosis. In part, it's because due to sampling error, which part of the myocardium you're looking at. There's variability in interpretation as well. So this wasn't really the best way to diagnose myocarditis, and and myocarditis still is underdiagnosed. We have options in the contemporary era. So we have our echo. We have biopsies as well. And also from what I read, the technology for looking at the specimen has also improved. So that's improved the sensitivity of PAT samples as well. And then of course, cardiac MRI is a relatively newer tool on the block. So the diagnosis of myocarditis has actually increased with the advent of cardiac MRI in addition to high sensitivity troponin. So back in 2005, the diagnosis, the incidence was about 95 per 1 million. And in 2014, it's 144 over 1 million. However, biopsy is still plays a very important role in the diagnosis. And it's important for us to recognize when to biopsy a patient. So the AHA, ACC, and ESC all have guidelines around it. So when you have unexplained cardiomyopathy of a new onset within 1 to 2 weeks, requiring inotropic and mechanical circulatory support, patients having electrical instability, it's actually a class 1 recommendation to go ahead with the endomyocardial biopsy. Otherwise, you can pursue cardiac MRI. So how I kind of, think about, this table over here is that if a patient is very sick, it's a new onset heart failure, and what else is going on, you ruled your MI, etc., you should try to get a biopsy if there's no other prohibiting factor. If not, you can pursue with a cardiac MRI. And this is because, it helps us rule out very important things like giant cell myocarditis and eosinophilic myocarditis, which have some level of treatment that we can offer in the immediate setting. So the patient, she continued to have a rocky course. We weren't able to wean her inotropes. And so we would have benefited from getting a biopsy. However, as you recall, her platelets were 20 when she presented, and they didn't really get too much better. So that prohibited us from getting a biopsy. So we ended up proceeding with the MRI for her, and I will show the results of her MRI. But first, I wanted to touch base on what sort of criteria we used to diagnose myocarditis. So this is the updated Lake Louise criteria to have an MRI-based diagnosis. So first, you look for myocardial edema, so you can look at it on your T2 images. And then you look for evidence of non-ischemic myocardial injury, so you look T1 images, so this includes fibrosis or hyperemia, and you can also look on your late gadolinium enhanced images. And then some of the supportive criteria include pericarditis or systolic LV dysfunction. The sensitivity of this is about 87.5%, and the specificity is about 96.2%. But what I read is that even if you have one of, not both of these main criteria, but one of them, it may still support a diagnosis of myocarditis. So we were able to get a MRI during one of her swan breaks. And this was this is the image. So you can see over here, it correlates with what the echo showed. So the LV is moderately dilated. The systolic function is very severely reduced, 10 to 15%. And then we noted, so these are her T2 images, and her relaxation time was greater than 60, and that is consistent with edema. So she fulfills one of the Lake Louise criteria. And then this is her T1 image. And then the T1 relaxation time is over 1100. And that is consistent with hyperemia fibrosis throughout multiple segments of her myocardium. And that is, again, fulfills the second of the major Lake Louise criteria. And this, I actually just took it directly from the report. Sorry. And then this is this one shows late gadolinium enhancement throughout multiple segments of her myocardium. So it should be black, but there are these areas of patchy gray and white. So she has partial to full thickness late gadolinium enhancement. And similarly, if you look at her short axis view, you can see this like gray white area throughout her myocardium. So she fulfills both criteria of the Lake Louise. So she has the edema. She also has evidence of fibrosis, and she also fulfills a minor criteria where LV functions down. And another finding was she had a apical mural thrombus, and as you can imagine, there was a lot of issues given her platelet counts and putting her on anticoagulation. So essentially, we confirmed the diagnosis of myocarditis. However, we don't really know what caused her diagnosis. The running thought was it is probably Coxsackie B, but at that moment, we're just trying support her hemodynamically and keep her stable. So we're going to move on to our second case. So this is, she presented to the UHCCU around the same time that the first patient was there. She was on the other team. So she is a 29-year-old. She also doesn't have any past medical history, and she came to St. Joe's for a 1-week history of malaise, body aches, shortness of breath, and pleuritic chest pain. And this is her echo. And her EF, as you can see, is reduced. It was read as 20 to 25%. She had moderate to severely reduced RV function. She was admitted to the CCU, and they got a right heart cath, and they were able to get a biopsy on her. And her, as you can see over here, her index was 1.53, so she was in cardiogenic shock. On day 2 of her presentation, she had VT storm, cardiac arrest, and she required CPR and cardioversion. She continued to have electrical and hemodynamic instability, and for this, she ended up requiring VA ECMO. They ended up putting a Impella as well for LV unloading, and she was transferred to UH for further management. And this is her PAT specimen, and we will go into it in a lot more detail in a little bit later, but long story short, this is consistent with giant cell myocarditis. So this was the results. So lymphocytic myocarditis with focal suggested multinucleated giant cells. This is consistent with giant cell myocarditis. So giant cell myocarditis, it's very rare, but it's very fatal. So it is caused by T-cell lymphocyte-mediated inflammation of the myocardium. Common presentation, so this patient actually presented very classically: acute heart failure, cardiogenic shock, ventricular arrhythmias. Actually, apparently 25% of patients have a history of other autoimmune disorders. And oftentimes, you know, these patients are young, they don't any other history, and it can be kind of hard to diagnose, and oftentimes they're treated for sepsis given fluids initially. Giant cell myocarditis was first described in 1905. This used to be an autopsy diagnosis before the advent of endomyocardial biopsies being routinely used in the 70s, 80s. The incidence is thought to be around 0.13 per 100,000, but this is likely an underestimate. And prior to the 1980s, so relatively recently, this is when they started treating these patients with immunosuppression, all were fatal or required cardiac transplantation. So the outcomes were pretty bad. And even now, the outcomes are pretty bad compared to other forms of fulminant myocarditis. So as you can see over here, this again is a more contemporary study. In 60 days, the rate of death and heart transplant approaches 62.5% compared to eosinophilic or lymphocytic myocarditis. And in 3 years, this is 81.3%. So again, outcomes are quite bad, and you know, early recognition is definitely helpful. So the pathognomonic feature for this is these multinucleated giant cells that you can see over here. And you also have diffuse inflammatory infiltrate consisting of lymphocytes, but these are these giant cells are pathognomonic. And this patient has clearly, these are her actual biopsy slides. She has these, you know, nucleated giant cells. So the treatment for giant cell myocarditis consists of kind of 4 pillars. So you have your immunosuppressive therapy, which I'll talk about in a little more detail. You manage the acute heart failure and the arrhythmias, hemodynamic support, and cardiac transplantation. So in terms of immunosuppression for giant cell myocarditis, first you give them your high dose steroids, oftentimes even before getting the biopsy sample. And if your suspicion is high enough, you just give them some Solumedrol. And then you use multiple immunosuppressives actually. So some common combinations are cyclosporin, azathioprine. You can use cell and TACT. If patients are very sick, you can give them anti-thymocyte globulin as well. And as I mentioned already, the long-term outcomes for GCM are not that great. In comparison to the earlier slide I showed, this one also includes recurrence. And as you can see, it's quite at 5 years, the rate of death, transplant, VAD placement, recurrence is over 50%. And there are case reports that have shown recurrence of GCM up to 8 years after the event. So what happens is these patients are on long-term immunosuppressives. So these are kind of, guidelines. So you can 1 year after treatment, you can stop your azathioprine or your CellCept. Prednisone can be tapered off if your LVEF normalizes, but oftentimes patients are kept on cyclosporin or TAC indefinitely. And in terms of other treatment considerations, you of course, have your neurohormonal blockade. It's not really well studied. So a lot of these, studies with not just giant cell, but fulminant myocarditis, the issue is that it's relatively rare, which is good because the outcomes are so bad. But, that also prevents, having these large RCTs. So a lot of it is kind of expert opinion based. So in terms of this neurohormonal blockade, GDMT, it's not really well established, but they do recommend trying to put patients on this after hemodynamic stabilization. And in terms of antiarrhythmics and ICDs, so this is a Finnish registry of patients with GCM. And they noted that of sudden cardiac death or VT was 41% at 1 year and 55% at 5 years. 57% of these patients required an ICD. 46% for primary prevention, 11% for secondary prevention. So the recommendations are to treat as other cardiomyopathies, consider implanting an ICD on a case-by-case basis. And one thing they recommended was maybe using MRI to see which, how much fibrosis they have, and then determining whether, this patient would benefit from an ICD. And then this is a schema from a JACC review article on this topic. So we kind of touch base on most of this. So, you have your new onset heart failure associated with hemodynamic or electrical instability. You do your standard workup. You want to make sure that it's not ischemic disease as well. If your clinical concern is high and the patient is sick, as we recall, it's a class 1 indication to pursue with a biopsy. So you do your biopsy. If it's GCM, you do your multi-drug immunosuppression, support them hemodynamically. If not, you think about other, factors. And oftentimes, as you can imagine, because of sampling error, you may not detect it on the first growth. So some patients may need repeat biopsies as well. This patient, in terms of her immunosuppression, she got her steroids. She also got the globulin, and she also got CellCept and TAC. She continued to have a rough hospital course. She had a lot of VT. I read in the chart that at one point she was on amioprocainamide as well as lidocaine. She had bilateral lower extremity paralysis. It was initially thought to be secondary to spinal cord injury, but they later diagnosed it as acute motor and sensory axonal neuropathy, AMSAN, which is a subset of Guillain-Barré. And she also became thrombocytopenic. However, she did improve. So she was able to come off of ECMO. She was on Impella for a little bit and milrinone for a while, but they were able to eventually wean it off. She had a sub-Q ICD placed, and from what I understand right now, she's still on the heart failure team and she's pending discharge to acute rehab. And this was her echo, the most recent echo I saw in the chart. As you can see, her EF has improved. She is doing better from a cardiac standpoint. So next, I'm gonna touch base on necrotizing eosinophilic myocarditis. very briefly. So this is usually a severe complication of a drug rash with eosinophilia and systemic symptoms. It can also go along with other eosinophilic syndromes such as Churg-Strauss or GPA. It presents with fulminant heart failure or sudden cardiac arrest. The outcomes aren't that much greater for this. Rates of death or transplant are up to 50%. And this one, the interesting fact is it often is accompanied by ventricular thrombosis or arterial emboli. So oftentimes anticoagulation is part of the management plan. These are some common drugs that are associated with this eosinophilic myocarditis. So as you can see over here, it's mostly associated with antibiotics. However, Spiro, HCTZ, and there are even case reports of dobutamine can be associated with it. So, you know, a lot of the tools that are in our cardiology box may be associated with this. So this is the tissue section. So these arrows, the solid arrows, you have myocyte necrosis, and then the open arrows, I think these like little red things show eosinophils. And these patients respond to high dose corticosteroids. Oftentimes the second drug is also used. And again, you know, as I mentioned, there's a lot of coagulopathy, so they may have thrombi. So oftentimes anticoagulation is part of the management. And then finally, I'm just going to touch briefly about immune checkpoint inhibitor myocarditis. So these are novel cancer therapies, came out in the last 10 years. So they're antibodies that target immune checkpoints and breaks. So it activates your immune system, so your immune system can go and attack the cancer cells. This was first associated with myocarditis in 2016, and there were 2 fulminant myocarditis cases that were reported. I believe it was published in NEJM. And since then, it's thought to have an incidence of 0.3 to 1% when multiple of these are used in combination. This is the largest case series. And what it showed was that usually after they start this, the onset of symptoms is pretty soon. So there is a temporal association with it. And the outcomes are also not that great. So 46% mortality. And the treatment is stopping therapy and starting patients on high dose corticosteroids. So this is something that I thought was important for us to touch base on. You know, a lot of our patients who come in with fulminant myocarditis, they're young, like some of them recover, and they want to go along, you know, living their life. So what to do in terms of activity recommendations. So this is from the ACC and the ESC. So the guidelines kind of say, you know, like they should not do competitive sports for 3 to 6 months because of the risk of ventricular arrhythmias. The ESC is a bit more conservative, 6 months, and then AHC is like 3 to 6 months after all of your other tests are normal. So I want to go back and talk about our patient, our first patient. So her hospital course was complicated by thrombocytopenia. She had a bone marrow biopsy, but we couldn't really figure out what was causing this. And again, we weren't able to get a heart biopsy. As you recall, on the CTP, she had these pulmonary nodules. She was occasionally spiking fevers. So we were thinking, oh, maybe she has an infection. So we didn't want to give her steroids straight up and just flare up this infection. We had ID come in and they recommended getting a bronch sampling these. And during the bronch, she actually arrested. She came back very quickly, but she did arrest. The bronch didn't really show anything. So she did end up getting a short course of high dose steroids. They were unable to wean her inotropes, and she was discharged on home milrinone. So Dr. Abdu saw her in clinic last week, and she's still on a home milrinone, but he's very optimistic that he will be able to wean the milrinone. We talked a lot about steroids and other immunosuppressive therapies in terms of, your GCM as well as the eosinophilic myocarditis. I want to touch very briefly on what the data shows in terms of lymphocytics. So usually, like this is the most common, so your viral etiologies of myocarditis. So this was a meta-analysis. It included, I think, about 9 studies, various types of immunosuppressive. Some signal with statin therapy, some signal with, so this started also immunoadsorption, IVIG, some signal with that. The most they noted was from combined immunosuppression. I believe these were, steroids, azathioprine. So there is some signal there that this may be helpful in lymphocytic myocarditis. And this what they're looking at is EF recovery. So they took these 3 studies that looked at combined immunosuppression, and they did a meta-analysis. And what they showed was a non-significant increase in LVEF. So EF increases by 13%. It's not significant, but there is a signal. I believe there are RCTs out there that they're trying to, study this, and they're also trying to study IVIG and other sort of immunosuppressives in terms of treatment of lymphocytic myocarditis. But the data is still very, very weak. So to summarize, lymphocytic, on your biopsy sample, you have dense lymphocytic infiltrate, can present in fulminant heart failure. Virus is most common. Treatment is mainly supportive, maybe some role for immunosuppressives, but we don't know. GCM, you have your multinucleated giant cells. Patients present very sick with hemodynamic and electrical instability. Treatments are combined immunosuppressive, so steroids, calcineurin inhibitor, and an anti-metabolite. You can also use IgG against thymocytes in these cases. You have your necrotinophilic myocarditis. So you see eosinophils on your sample. It's usually a complication of drug rash, prothrombotic intracardiac state. So there may be a role for anticoagulation in these patients. You put them on high dose steroids. And then you have your immune checkpoint inhibitor related. So I didn't show a path slides, but it's supposed to be similar to what you see on lymphocytic myocarditis. Again, there is a very long temporal association with it, which is helpful for us to kind of recognize what is causing the fulminant myocarditis picture. The treatment is stopping the immune checkpoint inhibitor and high dose steroids. These are, again, summary giant cell myocarditis. You have these multinucleated giant cells. You see eosinophils and in eosinophilic myocarditis. And in lymphocytic myocarditis, you see lymphocytes. I would like to thank Dr. Sennhauser, Dr. Smith for helping with the MRI images, and Dr. Abdu for helping with the entire presentation. I'm happy to entertain any questions, and here are my references.
Thank you, Saba. Excellent review. I don't have any pressing questions. I'll open it up to the group, see if anybody out there has any comments, questions at this time for Saba. But a good review with relatively happy outcomes thus far for these 2 individuals, which is obviously kind of rare.
Very, very happy with that.
Good talk, Stan Sherman. Once you treat the immune checkpoint inhibitors, they got on those for a reason. They have cancer problems. So can you retest those drugs again, or what's been recommended?
I am not sure about what I imagine. They don't recommend them again. I don't know if anyone else has a bit more experience with cardio-onc, but I'm not really sure what they end up doing.
I can't imagine they let him get immune checkpoint inhibitors anymore. I'm sure it's chemo plan B.
I'm pretty sure.
Saba, this is Mahmoud. Good presentation, very thorough review. Thank you very much for putting it together. And to piggyback on Dr. Sherman's comment, I doubt that anybody will attempt them again. And I think this raises a very important question: is how frequent is immune check inhibitor myocarditis? And if you talk to the cardio-oncology experts, they do say that this is very rare, and therefore they will attempt every possible way to make sure that this is truly the etiology of the myocarditis before stopping these potentially life-saving agents for cancer. So that's one thing that I think is evolving right now in the cardio-oncology arena. So we'll see how in the next few years what they will come up with. One thing, I don't have any questions, but just one thing that it feeds into the recommendations for physical activity in these patients. And for those of you who have rounded with me, my stand on life vests, and I'm not a very big fan of wearable cardiovascular defibrillators and life vests in general. However, in this particular case, I think you can make a point that these patients, especially younger patients who are probably more physical active than any others, maybe consider prescribing a wearable cardiovascular defibrillator for the amount of time that you're monitoring. And then by the time you feel that your risk of sudden cardiac death and ventricular arrhythmias is lower, you can kind of either discontinue it, or if they need an implantable defibrillator, you can consider it. But avoidance of aggressive physical activity, this is where cardiac rehab may be deferred a little bit. No contact sports, so on and so forth. So take it easy the first 3 to 6 months until the heart recovers is something I just want to emphasize on because it's important.
Thank you, Dr.
Go ahead.
I was going to mention the first patient, she ended up getting discharged on a life vest as well. And I believe she still has the life vest on from what I read in the chart.
Yeah, Stan Sherman again. We used to, if you had giant cell, we used to get the team in to look for transplantation. What percentage now are going to transplantation with giant cell?
That's a very good question. I mean, it's still giant cell. When we get a giant cell, the first thing we look into is their candidacy for transplant. Thank God this is not a common diagnosis, but this particular patient was not a candidate for transplant for multiple reasons, as you can see how sick she was. Transplant remains on the table, of course, on case-to-case basis.
Okay, well, thank you again, Saba. Excellent review, and thanks everybody for tuning in. Look forward to seeing everybody next Friday.
The preceding program is copyrighted by Emory University.